Okay, in chapter 3, we talk about neonates, which are infants right after birth, infancy, and early childhood. So, in general, what we can say is that through infancy, which infant means non-speaking, but through infancy, the behaviors that you see especially in newborns, is virtually all reflexive. The parts of the brain that are involved in voluntary behavior are not myelunated yet, which we'll talk about here in a little bit. So newborn states include sleeping, which they spend most of their time doing, and there's a reason for that we'll talk about here in a little bit. About 16 hours a day, 16, 18 hours a day, mostly in REM sleep, which is rapid eye movement sleep. And their rapid eye movement sleep is an active brainwave state. So they spend a much larger percentage of their time in REM sleep than they will later in life and that adults do. So, and there's also a reason for that in laying down the general functionality, predisposition for functionality in the brain, which we'll get to in a minute. They are alert at times when the visual system comes in the first 2 weeks. They begin to respond more and more to visual stimuli. They're not really processing yet. They're mostly responders to novel stimuli. You'll notice that as soon as vision starts coming in, babies are drawn to mini blinds, patterns, faces. There's actually a reason for this. It shows you that of what is valuable in nature. Patterns are valuable over non-patterns or random stimuli. So they're prone to spend more time responding to patterns. In experiments, this is actually measured by measuring gaze time. There's a device called a looking chamber, and you can do research with this by putting an infant in a looking chamber. It's a box with the sensors in it that pick up the direction and the amount of time that their eyes are focused on a stimulus. And then you can put different visual stimuli on the roof of the looking chamber on the inside and measure where they prefer to look and how long they look, and that's called gaze time. So they find that they have a longer gaze time for patterns than non-patterns. Crying is mostly generalized at first, doesn't vary much depending on the stimulus other than somewhat in intensity, but begins to differentiate into different kinds of crying, frustration, pain, and hunger. So not only does the baby differentiate in their expression and the way they cry, but the caregiver differentiates in their reading of their responses and determining what the problem is. So all their movements are reflexive. So these are the reflex arcs up and down the spinal column and the cranial nerves up in the brain. And there's no voluntary movement for the first few months of life. There are some functional limitations in the neonate, which makes them neonatal. As soon as these limitations are overcome, that is, they develop, then there are no longer neonates. Limitations include their vision. Vision's only rudimentary at birth. Takes about 2 to 3 weeks for vision to really develop. That's going to happen through myelination of the visual cortex and the optic nerves. Movements in neonates are only reflexive, like we talked about. Neonates can't regulate their body temperature yet. That's in the hypothalamus of the limbic system in the brain. And as soon as they're exposed to varying temperatures outside after they're born, then they will begin to pretty rapidly to regulate their body temperature. They don't have liver enzymes to metabolize proteins, amino acids, and that's why babies are born and become jaundiced pretty soon after birth, and they get their first feedings. That's hyperbilirubinemia, actually, and what's going to happen is that when they're exposed to sunlight, that's going to promote vitamin D synthesis. Vitamin D synthesis helps promote the liver enzymes that break down bilirubin, and then the jaundice will go away. So that's why you'll see in newborn babies a heel stick, so they can do a baseline bilirubin and kind of monitor that. But if they pink up and the jaundice goes away, then there's usually no worry about that. So they do have critical functions, though. These are the ones that are necessary for survival. And these parts of the brain, especially the brainstem, are myelinated and fully functional at birth. And that includes respiratory rate, heart rate, breathing, which is actually in a breathing and respiratory rate are both in the brainstem. Heart rate's in the brainstem, but heartbeat's actually in the sinoatrial node, in the posterior aspect of the heart. There's critical functions like taste, smell, and tactile sensation like pain and touch. It was thought years ago that babies didn't experience pain, and so they had a tendency to undertreat pain in infants after surgery, and then there was a change in the literature to encourage the treatment of more aggressive treatment of pain in newborns and infants. Their auditory function is functional at birth. Auditory sensation is functional at birth because there's actually exposure to sound before they're born. That's why they show a preference for their mother's voice over other voices, and voices that they've heard before through the amnion, they show a response to. And we'll talk about that when we talk about the looking chamber. Reflexes follow the cephalocaudal principle. So the easiest way to think about the reflexes is to go from the cephalic end down to the lower extremities. So the highest level reflex, or the one that's the most superior in the system, is blinking. And don't memorize all the nerves or anything like that. That's just illustrative of how this follows the nervous pathways going from the brain down to the lower extremities. So blinking is a trigeminal nerve and facial nerve reflex. Sucking is the 5th, 7th, 9th, 10th, and 12th cranial nerves. Rooting is the same group of cranial nerves plus the cervical reflexes. The Moro response is a rooting reflex, by the way, is you stroke a cheek and they turn their head and suck. It helps them to nurse. The Moro response is a startle response. If you lower their head and activate the vestibular system, they have kind of a tree branch grabbing sort of maneuver. They startle at a loud sound. This is thought to be an old vestige of pretty strong reflex you see in primates, other primates like chimpanzees and bonobos and rhesus monkeys, where if the mother lets go of the baby, they start to fall. They reach out and grab the fur on mother's body reflexively. So it's not an intentional process, it's actually a reflex. And that's so the mother can flee with the baby. Human babies have a version of this, but much weaker. Looks like a phylogenetic leftover. The palm reflex is basically when they first start to grab, they'll grab with the palm of their hand, wrap their fingers around it. You've probably had an experience of having a baby grab your hair or something, and they'll grab your finger. In fact, that's one of the tests at birth, to test their palm reflex. You put your finger in the palm of their hand and they'll grasp it, and it's an all or nothing response. So that's why it feels so strong. Then there's a stepping reflex, where if you touch their feet to the floor, they'll make kind of a stepping motion. It's obvious what that's for. That's to promote crawling and walking later on. And Babinski response, which is when you run your thumb up the plantar part of their foot or the sole of their foot, then their foot will arch and spread out, their toes will spread out. So that's the Babinski reflex. Since the reflexes are ascending from or descending from cephalocautal, what that means is that whatever reflex there is you're looking at, like a sucking reflex, if they have a sucking reflex, they're most likely going to have a blinking reflex. If they have a rooting reflex, then they're going to have a sucking reflex and a blinking reflex. If they have a Babinski reflex, they're likely to have all the reflexes above it because delivery and development of the nervous system proceeds from the top down. The APGAR scoring system is a newborn assessment, gives a quick score based on examination of activity, that is their muscle tone, pulse, grimace, which is their reflex irritability. You can kind of see that when you put ammonia under their nose and they turn and grimace. Appearance, like what color is their skin? Is it pale blue or do they pink up real good? That's a sign that their pulse oxygen level's up to 100%. And their respiration. So you can see these are just the very, very basic mechanisms that show that their brainstem and their most fundamental processes are functional. Brazelton extended the initial assessment, the APGAR, to provide a more sensitive scale with different measures on it. And this includes categories like social behavior, motor behaviors, control of self-control, their initiation of control, and stress response. Initiation of control is their baby's ability to quiet themselves. And stress response is their startle reaction. So this is the reflexive stress response, like what you see in the Moreau response. So a high score would indicate a neurologically well-developed. Low score would be sluggish infants who need help in responding to social situations or indications of possible birth trauma, brain damage, babies with hypoxia, or sometimes will wind up with a low Brazelton score. Now, keep in mind, when we talk about things like the APGAR and the NBAS, there's not much of a correlation between scores on these instruments and development later in life, only in the most severe cases, and that's because of the concept of neuroplasticity. And that is that forming any kind of a prognosis this early, unless you can see structural deficits like in an MRI or a CT scan of the brain, then it's going to be hard to form a prognosis because their ability to recover is so much better than it is in other groups, and neuroplasticity is so great at this point. So newborns begin as reactors to environmental stimuli. That means that there's very little myelin in the cerebellum. It's not functional yet. And so they don't really have an experience at the perceptual or cognitive level yet. We sort of assume they do, but when we interact with them, but actually they don't have much of an experience. A baby's experience is pretty much things coming into their view, sounds that they hear, things that they touch, that they feel tactily, pain, hunger, thirst, and those are kinds of stimuli that sort of come through their world, and have very little residual effect afterwards. They don't have executive function at this point because there's really not much function in the frontal lobe. They do increase in their capture of environmental stimuli. So, for example, they do get to where they make more eye contact and more seek out the stimulus environment. They react more to sounds, and as we'll discuss later, this is all sensory motor functionality that's going to change when they develop their first cognition, which is going to be object permanence, which we'll talk about later. So you can organize all of the activities that you see as cephalocaudal reflexes. So there's no intention, although it may appear there is. Sucking is whenever anything touches their palate and it stimulates their palate. That's why you'll see them sometimes suck their thumb on the sonogram because they've already in late gestation, in the late third trimester, developed that reflex. And so the reflex arcs organize. There's the cervical, thoracic, and lumbar spine reflex arcs, and then they're the ones up in the cranial nerves that are involved in sucking, grasping, stepping, and visual motor reflexes. What you can say about crying is it's mostly a response to internal discomfort and distress. It's a survival mechanism to let the caregiver know that they have a need or they need to be comforted. So babies cry most often when they're hungry, thirsty, or want to be held. And so they need tactile comfort. And so the most intense crying usually comes from some kind of pain. And probably the most common of that is gastric pain whenever they have, a bubble in their system or something that's intolerance to something in their diet. Then they'll have, cramping or gastric pain, and they'll have a pretty intense response. Other than that, crying in newborns is pretty much a generalized response. It varies some by intensity, but it's pretty much a generalized response. So this is one of those things that's going to develop from general to specific as they get to where they cry for different reasons, and we get to where we can read their cries. We can kind of determine what the origin of it is. So let's look at sleeping states. As we talked about before, their stages of sleep are established right after birth. Actually, before birth, they go through the sleep cycle. But during delta wave sleep, they're secreting growth hormone, but they actually have really pretty short periods of delta wave sleep. Most of their sleep period is rapid eye movement sleep or very active brain sleep that has a very active brain wave. And this is serves to stimulate the general myelination of neurons in the infant cortex. So that it lays down this kind of palette for the development of the neurotracts. It's kind of like an artist painting their canvas before they actually put a picture on it. So the REM sleep periods are much longer in infants than they are in adults. And what's going to happen over time is they're going to gradually fall into a sleep pattern where you have shorter periods of REM sleep at the beginning of the night, getting gradually longer as the night proceeds, and the longest towards the morning, which is much indicative of the way that older children, adolescents, and adults sleep. There's a condition that is talked about in the literature and a medical significance called SIDS, or sudden infant death syndrome. Sudden infant death syndrome is idiopathic death. That means that they've died, but there's no condition that can be identified as the cause of death. If they've smothered or they have gotten sick with some kind of an infection or something like that and died as an infant, that is not sudden infant death syndrome. So this is whenever there's no known cause of death and they just suddenly die. The occurrence of this is about 1 in 1,000, 2 in 1,000 infants, but some pathologists have concluded that since you can correlate sudden infant death with certain non-biological factors like social class, age of mother, the situation in the family, this has raised some questions as to what percentage of these sudden infant death cases are actually undiagnosed homicides or accidents, accidental deaths, and the site was disturbed because the infant was found non-responsive. So there's no way to determine exactly what caused their death. So there was a report written by a pathologist that did a study with sudden infant death syndrome, and his conclusion was, is since we have these social correlates, that probably the actual incidence of sudden infant death is lower than the 2 in 1,000. Temperament is kind of a predisposition for personality. It has to do with their response thresholds. So Rothbard looked at 3 dimensions of temperament that kind of describe different ways that kids respond to the environment. One's called surgency, which is their threshold for social stimulation, how field sensitive they are. And this relates to what we also see in introverts and extroverts. So if they're high in field sensitivity, which means that they're very sensitive to environmental stimuli, they startle easy, then that's what would be indicative of an introvert, somebody that seeks stimulation. Although at this point, it's too early to designate them as an introvert. Low field sensitivity is when they don't have as much of a response, so they have a pretty high threshold when it comes to response to environmental stimuli. And this is also consistent with what you see in extroverts. They have very low field sensitivity, so they tend to seek more environmental stimulation. The other dimension that Rothbard talks about is affect. Affect is their emotional valence from negative to positive. So level of irritability, anger, fear, frustration, how difficult they are to comfort, that would be their affect. Effortful control is their ability to inhibit impulses, ignore distractions, or comfort themselves. So, but temperament has some correlation with later in life, but the more years you go in past infancy, the more environment shapes certain responses, the social environment, and the baby's experience gets shaped by the social environment, and the less of a correlation there is between their personality and their temperament, although there are some relationships there, especially with regard to field sensitivity in the extremes. So someone that's highly field sensitive may continue to be highly field sensitive throughout their life and develop a personality that's affected by their high level of field sensitivity. Someone that's extremely low in field sensitivity and extroverted may continue to be extroverted through their life and seek a lot of social stimulation. Now you can see that in general physical development, they follow the cephalocolic principle. That's why babies have big old heads and little bitty bodies. And puppies and kittens do too. So head to body proportionality is going to change as they go through childhood, and that's one of the differences between adults and children is their proportionality of head to body, just like it is in other mammals. Now, also you're going to see functional changes from head down to the lower extremities. So as we talked about before, you get control over the facial muscles and the upper extremities before you get control over the lower extremities. So kids actually develop pretty good dexterity in their hands and arms before they manage to get much dexterity in their legs and feet. And they become more facially expressive before they actually develop as much expression in their bodies. And the same thing is true from the midline out. You get cephalocaudal development of the same things. They develop the central core muscles first, the ability to roll over, crawl, stand is mostly core muscles, and their hands and feet are mostly gross movement until they start to develop the really fine motor control in their hands and then fine motor control in their feet. During the first 5 years of life when the brain's myelinating, nutrition becomes a real issue when it comes to critical periods. So This is the critical period for brain growth, and as we'll talk about here in a few minutes when we look at the neuron and the growth of glial cells and myelin, babies need an adequate amount of triglyceride or fat in their diet, as well as protein and the essential nutrients. Fats and triglycerides are essential for the myelin development and the development of the nervous system. The best balanced nutrient for newborns is breast milk because it is predigested and it goes through mom's system, so it's not prone to being loaded with toxins, although it can be if she has certain things in her diet that don't occur naturally in nature, like small nonpolar molecules, dioxins, other toxins in her system can pass right on into her breast milk. But generally, babies tolerate breast milk better than they do formula, baby formula, for example, and they won't tolerate table food until they get fully developed in their enzymes, and that's their ability to metabolize proteins and fats. Although there's limited evidence that breastfeeding has much effect in their immune function or anything later in childhood or into adulthood. So there's a bit of a myth that if you have a lot of allergies as an adult, it might be because you weren't breastfed as a kid, but there's actually, we're much more resilient than that. And as a result, early childhood, the difference between breastfeeding and formula feeding in early childhood, it generally makes early childhood easier, but it doesn't seem to be correlated with much health in adulthood. So, but there are some early childhood exposures that can be dramatic in their correlation with later life problems. For example, it's been identified that high fructose corn syrup, which was by the food industry put into what they labeled as apple juice, but turned out to be corn syrup with apple extract in it, and fed to babies. There's availability of soda pop and really highly sweetened sugared cereals made out of corn syrup. There's a correlation between diets heavy in that and early childhood and type 2 but diabetes later in life. So, and that's why you can see a correlation between childhood obesity and type 2 diabetes and problems later in life, especially that first 5 years. Now, as we talk, that's why it's really important for them to be on much more of a balanced diet in that first 5 years. As we talked about before, malnutrition in the critical period in the first 5 years can lead to serious deficits that to be overcome later in life. This is why UNICEF and aid agencies set priorities when they go into aid groups to make sure that they get nutrients to the kids in gestation and those neonates and kids under 5. So it's mothers, neonates and infants and kids under 5 that are the highest priority, because this is where getting nutrients established in these starving populations can overcome pretty rapidly the effects of nutrient deprivation, and you can prevent some of the brain functional abnormalities that can result if you don't get to them in time. So that's why timing is everything when it comes to these early childhood cases. So the effects of malnutrition after the critical period, the longer it goes, the less plasticity there is, and the more there is the potential for these deficits to become permanent. So, and some of these have to do with water supplies in the third world. And of course, we're seeing it in Flint, Michigan, because there's a very large population of low-income kids that were exposed to lead influence water supply. And actually, my understanding is they're still, to some degree, exposed to lead. And lead is neurotoxic and can cause lifelong learning disabilities and intellectual deficits. So, and there's a variety of other health problems. But in the third world, there's also problems with parasites in the polluted water supplies, and they can have make it even more difficult for infants to absorb nutrients, which can lead to rapid starvation. So the first thing to go whenever there's a famine is the perishables. So the first thing you lose is the fats and proteins. And the diet becomes over dependent on grains and rice. And rice is pretty much a pure carbohydrate. And so there's certain kinds of disorders you can see in some populations where their food range is not sufficient. For example, there's a South American condition called kwashiorkor where kids are fed cornmeal almost exclusively, and they wind up with a real distended belly and nutrient deficiency because they don't have a wide enough range. They're not getting enough protein. So getting nutrients to pregnant moms, prenatal vitamins, cleaning up the water supply, and making sure that kids under 5 are well, that they have a balanced diet. And that's why the breakfast program for low-income kids and the school lunch program for low-income kids is so important, because it may be the only, and it's also important that the school lunch program be, healthy as far as diet goes, which they're not always. There's been some improvement in recent years, but there needs to be more attention paid to the kind of foods that kids are given in their school breakfast and school lunch programs. Let's look at the development of the nervous system. This is what we've been kind of alluding to for a while here. There's a link here if you want to look at, there's a video here that kind of goes over the development of the neuron and how the neuroaxon fires and the myelin. This is review. Other than maybe a question or two about myelin, I'm not going to ask you about detailed questions about the function of the neuron, because that's actually something you'd get in Intro to Psychology. But this little 5-minute video is really a good review. But if you look here, we have the neuroaxon, and this is where the action potential is, the neurochemical event that causes the firing of the neuron. So it goes from dendrite to axon terminals into the synaptic space to be taken up by the receptor sites in the postsynaptic neurons. So the important thing here is that babies in the late third trimester and in the first 5 years don't have a lot of neuroconnections. They develop those in a generalized kind of way, and most of the pathways of the brain are not myelinated, especially the ones in the outer part of the cortex. So as development progresses, the brain myelinates from the inside out. And some of the last areas to really develop a lot of myelin are up in the motor cortex in the top of the parietal lobe, and up in the front prefrontal lobe where cognition and thinking is. So as they go into REM sleep, what's happening here is that the stimulation of neuroimpulses in the brain is causing all the neurons to form connections. And these dendrites and axon terminals are finding other dendrites and axon terminals in a very generalized way. So this is at first, very inefficient system. So stimulating two things: the connection of these neurons, which you can see here in this GIF, and the speeding up of the neuroaxons as the stimulation starts to myelinate the neuroaxons. But to increase efficiency, the brain's going to have to prune off the unnecessary connections so that circuits can be formed. Those circuits are called neurotracks. So the myelin that deposits on the neuroaxon comes from triglycerides in the diet, and that's why a certain amount of fat is really necessary in the diet. And so putting someone, a newborn or a baby or an infant on a low-fat diet, or them being in a situation where they're not getting enough fat can be a significant problem. But the actual transmission of the impulse happens here at the synapse. And I'm not going to be asking you questions about neurotransmitters or synapses on the exam. But let's review for just a second, because there are some of these that are really important, and this is more complexity than you really need. But neurotransmitters define neural pathways. So some neural pathways are gamma-aminobutyric acid pathways, some neural pathways are norepinephrine pathways, some of them are serotonin pathways, some of them are dopamine pathways, and the neurotransmitter has an action that determines what the nature of that pathway is going to be. Some of them are excitatory, some of them are inhibitory, and they help control all the functions in the body that the nervous system is connected to. And so, like, for example, sleep regulation is controlled by the neurotransmitters in the neural pathways. Here's a little review of brain structure. Again, I'm not going to ask you a lot of questions about brain structure on the exam because that's an intro psych thing, but let's just review for a second, because how the brain's laid out is really important when you look at development. The brain develops from the inferior part of the brain up to the outer regions, and the middle of the brain to the outer margins. So, and actually it dies from the outside in. So it grows from the inside out and it dies from the outside in. So when someone is, for example, in oxygen deprivation, the parts of the brain that are deprived of oxygen first are those in the cerebral cortex on the outside. So you can see a general slowing of their ability to move voluntarily, think, process, retrieve, imagine. Those are the things that go first. The last thing to go is the brainstem, and that's down way low in the hindbrain. It's the most inferior portion of the brain and the most important for basic survival. So the cerebellum is going to be real important. It's that sort of independent structure there in the hindbrain on the posterior part of the brain under the occipital lobe there. The hindbrain is going to be real important because that's where your muscle memory is and a lot of procedural memory is. So coordination. So the ability to walk, grasp, crawl, run, all of the things that are skilled based get sent to the cerebellum for storage, and the cerebellum is also really important for coordination. So what you can say about the brain from an evolutionary perspective is that structures that you need to be alive for the next 15 minutes are going to be real deep, real low, and well protected. So you're not likely to bonk those structures. The ones that you don't need for short-term survival, like the motor cortex, the frontal lobe, especially the frontal lobe, they're out in the perimeter of the brain, in the frontal part of the brain, which is the highest risk part, because if you bonk that, you can still survive. And you may not be a lot of fun at parties or super bright, but you'll be able to survive. So again, this whole organization of why the brain's developed the way it is primarily a function of survival. It's well organized and engineered for basic survival. So let's just do some review of brain structures and their functions. If you'll notice, right in the middle of the brain is the thalamus. This is responsible for 4 out of 5 of the senses. Gustation, which is taste; tactile, which is pain and touch; vision; and audition, which is hearing. Processes through the thalamus. The olfactory bulbs actually lie in their own bony slot underneath the frontal bone. So, and are pretty closely connected to where the limbic system and the lower part of the lower part of the limbic system is the real basic emotional functions, which tells you, if you're an anatomist and you look at that, where olfaction is relayed, that tells you that your olfaction is your most critical survival sense. That's the one that, bad smells mean don't eat that. You can't get close to things that smell really bad. And that's your protection mechanism. Also, interestingly enough, smell is your sense that most rapidly retrieves episodic memories. So it can kind of put you into the past, the smell of cut grass or things like that, someone's perfume, things like that. The hippocampus is a structure that wraps around the thalamus, and that's responsible for memory encoding and retrieval. You can't really see it well in this picture, but in fact, the thing they have pointed out is the hippocampus really doesn't look like a hippocampus. The hippocampus really kind of wraps around the thalamus. And the lower part of the hippocampus that's right up against the amygdala, which is where irritability and anger are, that's where your episodic memory is. That's the most automatic form of memory you have. And that's why certain memories can retrieve emotions real quickly if they're traumatic memories, or that's why you never forget anything you ever argued with somebody about, or things that elicit a lot of emotion tend to get stored really rapidly in your memory. The pons is where the sleep-wake cycle is, and that's where your circadian rhythm processes. And then the medulla there in the lower part of the brain is where heart rate, respiratory rate, and vasodilation and constriction. And then the cerebellum we talked about before, that's your storage of motor functions and coordination. The hypothalamus is interesting because that's where your drives are. Hunger, thirst, sex, and temperature regulation are all in the hypothalamus. Now, the question is, why is temperature regulation in the hypothalamus? Well, that's because the hypothalamus, and that's not a very good picture actually for showing you where the hypothalamus is. But anyway, the hypothalamus, temperature regulation in there, the reason it's where it is because if you're too cold, you get an irritable drive to find warmth. And if you're too warm, you get an irritable drive to find coolness. So the hypothalamus is directly connected to the amygdala. So there's a lot of emotional response that gets impulses from the hypothalamus. Like there's a strong connection between being hungry and being anxious or irritable, being thirsty and being anxious and irritable, sex drive and emotion, both in attachments and in frustration and deprivation. So that's why the hypothalamus is so important for that. And I think it's important about the hypothalamus is in this area called the VMH, or the ventral medial nucleus. That's where mate selection is. So actually, whether we select opposite sex mates versus same sex mates on a continuum is actually wired into the hypothalamus and the VMH and in mammals. And so most people select, and most animals select opposite sex mates, but a certain percentage of the population, a minority of the population, will select same sex mates all the time, or same sex mates sometime and opposite sex mates sometimes. So mate selection is actually in the lower part of the limbic system, driven mainly by the hypothalamus. Understanding where the cerebellum is and what it does also is part of an argument that we want to expose very young children to a variety of tasks and experiences. And the richer their variety of experiences, the more foundation is going to be laid down in the motor cortex and cerebellum for harvesting those skills later on in life. And so that's why concert violinists, athletes, people like that tend to start their craft at a very early age, before age 5. So a violinist, for example, or a guitarist or a pianist will play arpeggios for hours when they're learning, and those combinations of fingerings on the keyboard or the that on their instrument will store as patterns, and those patterns, even though they may fall out of practice if they don't play for a while, they're always there, and so they can be harvested later on. The notes on a staff can be paired with these patterns and stored as well. So the visual stimulus of the notes on a staff. So when a violinist looks at a sheet of music, they're not really consciously aware of where the notes are on the staff or how that's plugging directly into their responses in their cerebellum. That's why violinists can read music so fast and why they can play so fast. That's way beyond what conscious decision could do. Conscious decision is reserved just for expression. And that's true with athletes as well. Athletes can, in baseball, for example, if you look at a shortstop playing, their responses are largely automatic and cerebellar, involve a lot of muscle memory. There's some nuance that can be affected by strategy, but basically the foundation's there for all of the basic movements. So if you imply this understanding of the regions that are important for the development of exceptional fine motor skills, you've got cerebellar functions, which we talked about. That's muscle memory and the neural pathways and storing repeated movements. And then you've got the sensory motor cortex, which stores the initiation of those movements and the coordination of proprioceptive and kinesthetic feedback that's involved in all those, and all of that's connected together into a system. Our understanding of that then should be reflected in how we program in education. And it's one of the arguments for not having such a clear distinctions between academic and extracurricular, because it turns out that there's so much overlap between academics and extracurriculars in the development of skills that may come in handy later in life that turns out that the extracurriculars are probably as important as the mainstream academics. Okay, so let's look at the formation of connections from general to specific. Like I talked about before, REM sleep provides a generalized stimulation of neuron connections in the brain, and that lays down kind of a palette for neuroconnections. As babies develop, they form more and more connections, and you can see up until they're about 2 years old, these connections get really dense. And so what happens is that you get an increase in neuroconnections, but a decrease in efficiency. So what happens is that in year 3, 4, and 5, somewhere around in there, what's going to happen is that as they practice those pathways, the ones that are needed and practiced are going to be retained, and the ones that are not needed are going to be pruned off. And so with synaptic pruning, you actually get a reduction and a specialization of neural pathways, and that makes it more efficient. So by age 6, there's a lot of myelinated, pruned neurotracts in the brain, which makes the brain much more efficient. And that's why you see this burst of skills. And you also see exactly the same when you're looking at language acquisition. And that is that they prune off unnecessary phonemes and morphemes in their language acquisition, and language becomes much more specialized. After about 3 or 4 years, they start to develop an accent and retain the phonemes for the languages they speak and lose the phonemes for the languages that they don't speak. And that's another form of pruning. So brain plasticity or neuroplasticity is the flexibility of the brain and its ability to acquire new information or new skills. Okay, that's called aptitude or fluid intelligence. And then also it is the ability of the brain to recover if any functionality is lost due to injury or disease. So up until about age 5, the brain's highly flexible. And so there are certain surgical procedures that are possible in very young children that are not possible in older kids or adults. And that's like, intractable epilepsy with a untreatable seizure disorder. They may opt in very young children to do a unilateral hemispherectomy where they actually take out part of the cortex on one side of the brain and let the other side reassign those tasks, which it will do in neurosprouting. So that's a sign of that. Babies that are drowning victims, young children under age 5 that are drowning victims, have a better prognosis for recovery than adults do. Cancer patients who've had to have an excision of a tumor or brain surgery for a tumor in the brain also have a better prognosis than their older brothers and sisters or older kids or adults. So what that means is that brain flexibility accounts for the better aptitudes early in life, the ability to acquire new skills early in life, language acquisition early in life during the critical period, and the decline in all of those things as they get past age 5 and start to get older, then they actually lose some of their aptitudes and that brain flexibility and experience substitutes for it. So this brain flexibility and neuroplasticity and its relationship to the environment brings up some kind of social questions like the quality of education for kids in the lower income brackets versus the quality of education for kids in the upper income brackets and private schools, the kinds of resources that lower income kids have at home versus the kinds of resources that kids in the upper income brackets have at home, and just in general how rich their environment is can have dramatic effects on the outcomes. And when you look at nature versus nurture, this is really important on the nurture side. So it may sort of encourage us to think about things like, does no pass, no play make any sense? Take away one activity to try to punish somebody into being better in another activity. Like take away a sport because you want them to do better in reading or in their math class. What that does is it kind of defines some of those activities as less important and some of those activities as more important. We're not sure exactly what activities are going to be more important and which ones are going to be less until we see what kinds of things they're interested in later in life. And you can have undiscovered aptitudes when you have deprivation states. So that can be a consideration when you're looking at, is their educational program broad-based enough? There's two kinds of growth that we look at, so we can introduce those concepts now during the critical period and also later in life. Okay, and that's experience expectant brain growth and experience dependent brain growth. So experience expectant brain growth is the basics. That's the normal range experiences, everyday kinds of experiences that lead to the basic kinds of functionality that you have to have just to function within the normal range. So environments that are highly impoverished can have deficits in experience expectant brain growth, and that puts them at functioning below the normal range. Experience dependent brain growth is all of the specializations. This is the skills-based, specialized kind of brain growth and that comes with specialized skills. This is what academic tasks like reading, arts like music or drawing, athletic abilities, anything that builds these special skills is experience dependent. And that means that the experience has to be there. That specialized experience has to be there. And so that's what differentiates kids one group from another or differentiates them by social class or richness of environment. And when you have an adequate social safety net, basically the common skills are there. The experience expectant growth's there for most kids. But it may not include all the experience dependent kinds of or exceptional kinds of specialized developments that are available in a richer, more diverse environment. So specifically, let's look at motor development and dynamic systems theory. In experience expectant growth, this is the standard walking, grasping, and early utterances or language. And so these are aspects of the environment that are common across situations, only except in in situations where there's a lot of deprivation. Experience-dependent growth, being the specialized environment, provides opportunities that vary across situations, social class, skill of caregivers, qualities of communities and schools. Now, in dynamic systems theory, what you're looking at is the effect of the child or the caregiver on the child, and then the caregiver's response to the child's progress. So you have a dynamic system between the sociocultural world, the biological age of the child, and their predispositions, and those form a dynamic system of feedback and initiation, and that's what leads to the outcome. At first, brain development is bilateral. That means that, and again, this falls along the general to specific trend, but it's bilateral, which means that both sides of the brain are developing, and their movements and skills are basically very generalized and non-specialized. Okay, in the first 5 years, though, you'll start to see some specialization of one hemisphere over another. And usually the first sign of that is handedness. So when they start to prefer one hand over another, most people prefer their right hand over their left. That means that the brain is starting to lateralize. So it'll assign tasks to one side or the other. For example, language ability is, for most people, is in the left frontal, left temporal areas in the brain, and Broca's area in the left frontal area, and Wernicke's area in the left temporal area. Arithmetic, spatial reasoning, and right hand, right leg coordination are also on the left side of the brain. The right side of the brain is where spatial awareness and creativity and inductive reasoning is, and left leg, left hand functionality. So that's why if you see someone with a unilateral brain injury, like a stroke in the upper right hemisphere, they'll have left side weakness. If they have right side weakness, that's a sign that the stroke is in the upper left hemisphere of the brain. Now, people that are ambidextrous don't have a preferred hand. And there are some activities that lead to ambidextrous functioning in specific activities, like baseball players who can swing a bat both ways or throw a ball both ways because they've started to learn to do that in an early age. Drummers that play in an ambidextrous way have mastered a non-dominant way of their motor function. In fact, athletes in general, in some sports like football and basketball, become pretty ambidextrous because the sport itself rewards having bilateral abilities, the ability to dribble a ball both ways, the ability to catch a ball both ways. You know, those are things that are rewarded in those sports. A person may lose a limb, like I've dealt with patients in the Army that had amputation injuries. And if they lost their dominant hand or dominant arm, then it was quite a task for them to learn to replace that function with their left, their non-dominant hand or non-dominant arm. They'd learn to write with their non-dominant hand or and to do things with their non-dominant arm. Interesting enough, with physical therapy and occupational therapy, they actually get really good at doing that. So, and especially in the young ones, people in their early 20s, late teens, they can adapt pretty well. Now, if you look at the development of cognition, early signs of the development of cognition, and that would be object permanence and Piaget stage, which we'll be talking about later. The theory of mind starts to develop. Babies become increasingly aware that you can see them and they can see you, that there's sort of me, not me. And that shows that they're getting some development in the frontal lobe. Young children will begin to develop a sense of their own thinking, like they'll hear themselves, they will actually be aware that they're solving a problem or that they want something. They'll start to engage in impression management, like modify how they respond to you to try to get a certain response, or modify how they ask for things to try to get a certain response. It's called the theory of mind. So later on, we'll be talking about self-concept, but the self-concept has three components: self-image, which is their ability to sort of detect how they're being perceived by other people; self-efficacy, which is their own level of confidence and beliefs about their abilities; and self-esteem, which is the affective result of self-efficacy. That's their general sense of value, from a positive to a negative on a continuum. And a myth about self-esteem is that self-esteem is an entity in itself. Self-esteem is directly related to self-efficacy. Self-efficacy is more cognitive. Self-esteem is affective. So self-esteem is actually a reaction to self-efficacy. That's why the change, or to change self-esteem, you have to change self-efficacy. Self-efficacy is a learned process. It comes from what we call a contingency-based environment. That is, when people make a temporal connection between their behavior and what happens to them, then they're operating under the contingencies in the environment. And they get an intuitive sense for how much control they have and how much confidence they have that they can initiate consequences in the environment, bring about good things, avoid bad things, or connect bad things and learn from them. So their capacity to become proactive controls of the environment is going to improve their executive function. Executive function is the ability to elicit control over emotion. So when Rotter did his locus control studies, he connected self-confidence or efficacy with people that have a high level of confidence that they're in control of contingencies in the environment, and low levels of self-efficacy with people who have a weakened sense that they have control over contingencies in the environment. And so that's why externals tend to be more subject to anxiety and impulsivity and things like that. So that's why you see, if you measure locus of control with a Rotter locus control scale, and you measure the same people with a Rosenberg self-esteem scale, you find that internals tend to score as having a higher level of self-esteem, and externals tend to score as having lower levels of self-esteem.